want to thank you all for having me here. It's a pleasure to speak to you and with you again. We were here last year and our topic was applications of the 3D wave in the office and how it's helped our conversion rates and our outcomes. And today we're actually going to switch more to the scientific end of things and talk about some of the work that we've done with the instrument in our office. But in large part, you know, I couldn't get any, it would be inappropriate for me to get any further without suggesting literally how this instrument has changed the way our office is operating. This machine sees every single one of the patients that walk through my doors. It is a wonderful device. It gives me my auto refractions on patients that come in and they're looking for glasses, although primarily my practice is surgical. I have 3 offices that in essence work with corneal patients and cataracts, and with the change to premium IOLs, it certainly is a wonderful tool. Now every manufacturer is coming out with their new high-tech device, and in large part with these lifestyle lenses where it was premium lenses before and then it was accommodating lenses or presbyopia lenses has really changed because of the way we're looking at things. But in large part, even with the toric and the Technis multifocal, the Alcon, whatever lens you're using, the Resume, Restore, Synchrony, Lens Tech, whatever that may be, in large part, one of my biggest concerns is when this happened, when we saw these premium IOLs, and I will say that our conversion rate, you know, we're very proud of, is about 30%. But there are a number of reasons why individuals do not go with toric in lifestyle lenses. But in the process, when we suggest that as surgeons, it tends to devalue a monofocal implant, or it tends to devalue the lens that is considered the standard. And it's not necessarily the job of the patient to pick the implant, it's the job of the surgeon. And everybody has their algorithm as to which lens should go into which patient. And we speak for other companies, and in large part, some of the topics that come up is to suggest that one implant is right for everybody, and that is not the case. And to then suggest that if they're not getting a toric or a multifocal or an accommodating lens, that somehow they're getting less of a product is really a bad way to present information to a patient, because I think they see that, and they will see that on your face when you're talking to them. The instrument that I think has really helped us in discussing this with patients, not only able to present them information, but give me the information that's needed in order to run an efficient practice, is the 3D wave. It's an autorefractor, for those who do not know, a keratometer, topographer, placido-based, pupilometer, which I think is great. And I don't know how many people, how many surgeons do we have here? You get pupilometry on everybody? Pupilometry, key, mesopic and photopic. Are you doing it handheld or do you automated version? How are you doing it? Infrared camera or the handheld? Yeah, so I mean, obviously that's a wonderful tool. The nice thing about this device, and obviously you shut your door, make it as dark as you can get it, you know, make sure you get scotopic, right. You do it yourself? Okay, have somebody else do it for you. And you get, I'm sure you get topography as well on everybody. Yep. Okay. And then how about wave scans? Yeah. That's right. So how are you getting your wave scans at the moment? What instrument are you using? It's not the 3D wave? Okay. Good answer. Right. And in large part, I think that typifies, most practices. When a patient comes in, you're doing this kind of circular patterns and you're juggling all these patients in order to get the right information. We do block scheduling. That's also been a nice little trick that we've adapted. And in addition to that, everybody that walks through the door is sat at this instrument, and in a matter of 45, 60 seconds, I have all of that. I keep my room illumination low. So I'm in essence getting less than 3 candelas per meter squared. So it's low mesopic, certainly very close to scotopic. And then I also get a placido flash on this device that gives me photopic. Okay, so it's a wonderful instrument. And more importantly, what it also does is it gives me pupil center. So if I'm looking at a patient postoperatively, I'm able to identify my lens position with this instrument. And again, it's 90 seconds, a single instrument, and then they're off to the races. The interesting thing interesting piece to this device that I think is probably the most impressive is the way that Marco has adapted the line of sight issue with the Placido topographer and the wave scan. And we're going to get into our study in just a moment, but in large part similar studies were done where they took a patient, gathered their corneal wave scans off of a topography, a Placido-based instrument, and then transitioned them over to a wave scan. And what that does is, in essence, changes the direction of line of sight. The 3D wave acquires its information much the same way all topographers do, off of the vertex normal of the cornea. Okay, so that gives you centration on the vertex normal, whereas wave scans tend to do it on pupil center, line of sight. Well, if you're looking at less than normal angle kappa, 3-4 millimeters, 2 to 3 degrees of change, it doesn't change a whole lot the wave scan other than maybe a little bit of coma. Okay, now you can argue that until you're blue in the face, and we can discuss how that may affect outcomes. But the fact of the matter is, one machine gets it all through line of sight. So the corneal and total eye wave scans are going to line up a whole lot better than switching a patient from one instrument to another, potentially getting alignment issues and cyclotorsion issues. The answer really here is trying to get to the carrot or the piece of cheese as quickly as you can when it comes to a pre-op assessment or post-operative assessment or any assessment of patient. And the 3D wave does that. Now, we don't need to get into the internal workings of the instrument, but it is a double pass method using essentially what we all learned in the early days of residency, or should have learned, is retinoscopy streaking. It's a dynamic skioscopy set. We all know how light is bent as it goes into the eye, and then as it comes out, it tells you a whole lot about, or tells you a fair amount about what the optics of the total eye system is. Well, specifically for our discussion, we're going to talk about spherical aberration. In essence, all the major companies have an aspheric implant, and the idea was that you're taking light rays that tend to bend more precipitously at the edges of a lens, giving you levels of glare and halo. In a pure optical system, the peripheral aspects of the implant should graduate the light rays so that they all come to a single focal point, improving the piston, or in essence, making a more true image. The average cornea, as assessed by Biko in a large group of studies, as well as Holiday, and they correlate quite well, is that the corneal spherical aberration is plus 0.275. And in the young, I guess, second, third decade of life, the lens tends to cancel that out, so you're getting, in essence, almost pure neutrality of the optical system, giving you a pure image from object to retina. Now, each of the major companies have come up with their version of an aspheric implant. The Technis tends to address the most with minus 0.27, so in essence their goal is neutrality. The Alcon platform addresses a little less, so to suggest that there may be a little bit of positive spherical aberration. And the debate as to how that affects vision, everybody has their take on it. But if you look at most of the literature, they're going to suggest that, again, getting as close to zero is ideal. Now, we could take it a step further, and we know that there's a very important interaction between lower order aberrations, sphere and cylinder, and higher order aberrations. But for all intents and purposes, for our purpose here, we're going to just assume that zero is the best target here. The other issue that I think is critically important, and something that we all, as surgeons, identify, is lens position. The effective lens position. The center of the lens, particularly with these aspheric implants, have to line up with line of sight, because if it's off as little as 0.3 to 0.5 millimeters, there's going to be an amount of aspheric inducement. So the B&L lens and now the Softtech lens have a neutral implant that, in essence, if it's off by a little bit, you're not, in essence, going to eliminate all of the corneal spherical aberration, but you're not going to generate. So when looking at the pyramid of spherical aberrations from low to high, the one that we're most concerned with is right in the middle, 4-0, which is spherical aberration here, the Z40, but that doesn't mean that we're not going to be addressing the third line as well, which is the coma, as well as trefoil. Primarily, the issue when it comes down to brass tacks here is not what do these images look like to a patient. They couldn't care less. It's the way it affects the image as it enters the eye. And if you're talking about a small pupil, for all intents and purposes, it doesn't make a difference. It's when you get over about 4.5 to 5 to 6 where you start seeing these, again, peripheral rays addressing the image as it enters the eye. Now, in a purely piston optical system, you should get a point source of light. But with deviations from that, when you start inducing these high order aberrations, you're getting degrees of significant directional aberration as well as spherical aberration. And that's what has been addressed in prior studies when it comes to performance. Now, again, in large part, how does the rubber meet the road? And when you're talking about an aberrated eye, again, we're addressing only about 10% of the image quality. To suggest that if we do nothing to spherical aberration in a 7mm pupil, that would be in essence the equivalent of a defocus, of missing our target by about 1/4 diopter. So most of us would say, hey, look, if you're within 1/4 diopter of your intended goal at the end of cataract surgery, that's pretty darn good, okay? But what's happening is our outcomes aren't necessarily changing. Precision and the expectation from our patients are changing. Premium IOLs, toric IOLs, aspheric IOLs, individuals are talking to friends and they know that outcomes can be achieved. And quite honestly, I can't tell you how many times I have a patient come into the office from another surgeon and they are not emmetropic following surgery, despite the fact that they may be 20/15, and they're unhappy because they talked to their friends and found out that they don't need spectacles after surgery to drive their car. So the expectations have changed. So I would agree with colleagues when we suggest that, I was at a talk last night that 1/4 to 1/2 diopter of defocus is inappropriate, and I would extrapolate that out and suggest that if you're not managing your spherical aberration, if patients are noticing glare and halo at night, that's inappropriate because we now have the ability. So here's a representation of the defocus. Again, trying to give you an idea of what we're talking about. A completely neutral image is on the top left. Degrees of greater residual spherical aberration are from right and then down into the left. And this would be the equivalent of a spheric implant, okay? And that's assuming 20/20 acuity. So that gives you an idea of what we're talking about. But how does the patient see that? Well, at night, this is what they're looking at. They're getting images to suggest that there's this secondary halo around targets. And I don't know how many patients you have that are astronomers or moon gazers or stargazers, but this is what they're really concerned with. It's the image around the image of interest when they're driving down the street. The original studies looking at the aspheric implant, the first to be released, was actually the Technis multifocal implant. And they addressed, as I said, complete neutrality. That was their goal. And what they found in their study is when they reduced spherical aberration, patients improved their performance, which in essence gave them, in reaction time, about a 1/2 second. So what's a 1/2 second? Doesn't seem like a whole lot. But if you're 75 years old driving at dusk or in dawn and you're going down a busy highway, a 1/2 second, 60 miles an hour is about 3 car lengths. And identification of street signs, where's my exit, what's the sign say? That's really what they talk about. And we have the ability now to address spherical aberration on every patient, or at least I do in my office. And that's exactly what we did as our study. We looked at 40 patients. We stratified their eye based on their corneal spherical aberration, and then we would assign them an implant that was intended, based on their corneal spherical aberration, to reduce their total ocular aberration to 0, okay? And this is our graph here, identifying that. I don't expect you to be able to read that, but in essence what it said is that if they had higher than average spherical aberration, they got a Technis lens. If they were somewhere between 0.235 to 10, they got a SN 60 wavefront lens, and then below that they would get a neutral B&L implant. Afterwards, we then brought the patient in, we maximally dilated their eye, and we checked their spherical aberration of the total eye through the wave scan profile of the 3D wave. So again, one instrument did all of this for us. So here's an example of a patient that we had. Notice the point spread function in the upper right quadrant. Again, that is a graphic depiction of light transfer from an object to an image. A point source of light goes through the eye, and if the image is true, the truer the system, it'll come to a point on the retinal surface, okay? There's also something called the Strel Ratio, which this instrument gives you. If you touch on the top right corner of your machine, you can actually bring it up. A Strel Ratio is a numeric value for image purity, and we've all probably heard of seeing the graphs, particularly with the lifestyle lenses, addressing image purity when it comes to a modulation transfer function. But for all intents and purposes, it's pretty much the same thing. It depends on how you want to look at it. But I think what is most valuable, again, clinically applying this, is being able to show a patient what you're talking about, okay? When you try and explain to them that there's an idea where you would like to reduce glare at night, they don't, they can say, they can refer back to their experiences, but you can show them, this is what I'm seeing when we image your eye. So what we did is we placed a Technis implant given this patient's preoperative corneal spherical aberration, and we reduced it, okay? And if you look at the ocular spherical aberration, it's exactly what you would expect. We get it as close to zero as possible given the image, and the point spread function changes dramatically. And patients, they respond to that. It's a real pleasure to be able to take the pre-op image, show it to the patient, and give them the post-op image afterwards and say, hey, look, this is where we've come. And not that I want to encourage you to be happy, it's just that it certainly allows them to actually hold on to something and say, yes, indeed, things are quite good. And they feel a little bit more comfortable, if they plan to, say, drive later in the day and they know they may be out at night. I'm not certainly suggesting they do any trick driving or race car driving, but it's something that they can do to certainly feel a little bit more comfortable about your outcomes. So the study, in large part, as suggested, took as close to a normal population as we could, given 40 patients, given the relatively small size. And you can see our graph here is a fairly good bell-shaped curve. What the image on the left suggests is the x-axis is our preoperative corneal spherical aberration. The y-axis is our postoperative total ocular aberration. So obviously, those who had higher corneal spherical aberration on the right, or the right side of the graph, we reduced them as much as we could, given the numbers here. Our scales are a little off, so what you're going to see is that if we have a patient who started out with greater than 40 microns of positive spherical aberration in the cornea, we got them down to less than 0.1 on average. And the fact of the matter is, what you can see here is that with the spherical equivalent of minus 0.13, the total ocular spherical aberration for the entire group here is less than, I guess, 2/100 of microns of spherical aberration, which I think is certainly suggestive that this is a feasible way to address patients with monofocal implants. In large part, we've collaborated with M&S to start taking this same set of patients and looking at their visual performance. And this is a contrast sensitivity device that looks at the spheric IOL. So the other aspect is we age match controlled them to a group of individuals who had prior spheric implants. So there was no addressing the spherical aberration at all in this population, and we compared it to our optimized patients, and you can see the photopic performance was considerably better on the right compared to the normal age-matched non-cataract patient. Okay, now it's kind of a backwards way of looking at it. I mean, in essence, in large part, if they still have a little bit of a cataract, they shouldn't perform as well given the age. But the fact of the matter is this: cataract aside, aspheric implant, spheric implant under photopic conditions. And again, under small pupils, that really shouldn't do anything. You're going straight through the center of the implant, shouldn't do anything as far as performance. But what you will see here is when we compare mesopic performance, the image on the right actually is almost as good as the spherical performance under photopic conditions. So again, I'll back that up, and I don't know how well that presents, but the aspheric implanted individual did as well under low light conditions as the spheric implanted individual did under photopic conditions. And in large part, with the growing desire for precision in outcomes, and patients are becoming more and more educated prior to walking in the door, they know what they want, and we have to be able to deliver. And what was once a very difficult prospect is getting as much information as you could in order to address the patient's needs, whether it be a premium lifestyle lens or a monofocal implant. The outcomes are really what's going to separate you from others if you're not measuring spherical aberration. And this certainly suggests quite well that doing so is going to allow for patients to do considerably better. So I thank you for your time. We have some other slides here that are unrelated, looking at some post-LASIK images and some toric implants and some multifocal implants as well, but we can probably stop it there if there are any questions.
What's your setting on your aberration? Do you use 4 and 4, 4 and 8? What do you use for your default for your wavefront?
4-0.
4-0.
Yeah. And then we use this. What are the settings on the wavefront as far as you're talking about the measurement for the spherical aberration? Yeah, I think it is. I think we have 4-0. I have to go back and check, but I'm almost positive. We're taking the lower number. That's what most of the studies are doing. We assigned it. Now, obviously, the big debate when it comes to measuring spherical aberration, and you can, that's where a lot of the times if you're presented information about image purity, what I find to be most important is look at the level of light, and then also looking at pupil size. For instance, and again, I use every lens out there, so it's not that I'm bashing one or the other, but a common trick would be, say, for prior to the 5.0 platform for crystal lens, they like to make their pupil size 4.5. So it certainly is going to give you a purer image, whereas others, I think the standard for most research studies, if you're looking at model eyes and so forth, the standard is a 6 millimeter pupil, 5.5, 6. So I just figured I have the ability to address it anyway. I adjust it at any point, so I took the largest. I took it right to the optic edge.
Do you use this kind of stuff for somebody who wants it multifocal?
Oh, absolutely.
This is really more of a monofocal spherical ab, but what are the
So let's do this. Here, I'll show you. I got one here that I think this is a post-LASIK case. We are actually in the midst of working with Fujita-san, who in Japan helped design this for Nidec. And then again, those who don't know, Marco is actually marketing this device here in the States on behalf of Nidec, and it's a wonderful tool, but I've had the opportunity to collaborate with him. It's worth mentioning a study came out, I'll stop here, shortly after our publication that suggested that there may be some difficulty with reliability. And their point was that cataract surgery induces higher order aberrations. Well, there are a number of studies that show that if you're precise with your small incision or micro incision cataract surgery, you shouldn't. And where are you going to see it? Well, obviously, we all know that we induce about 1/3 of a diopter of SIL, keratometrically, correct? Well, here's a post-LASIK patient. Now, I do not trust the central case, okay, but if you're getting a SIM-K on an individual, that's an average image of the cornea. And you can look here. Here's pre-op Ks, okay? And again, for those who aren't aware, the myopic LASIK will generate more positive spherical aberration. Post-myopic LASIK generates more positive spherical aberration. So we grabbed a Technis in this case, and post, the only thing that changed with micro-incision cataract surgery, if you look at the Ks, 42.35, 42.0 up here, is in essence the axis. Well, here, I'll show it to you. Let me back it up. The axis. It's identical. Okay, so there's certainly reproducibility on the device. And if you're looking at, again, total ocular spherical aberration, this is just the eye. This is going from front of the cornea, hitting the retina and bouncing off. We're reducing spherical aberration as well. So that's a post-LASIK case. And we are working with Fujita-san now looking at the refractive map to see, much like, say, Orange, when they do an aspheric measurement, looking at the refractive map to tell us a little bit more about that. But I'll show you here see if I can grab I think we have a Restore implant here. This is actually a form for us. Let's see here. No, I'm sorry. So, for instance, this would be this is one of our patients for the Restore implant. Okay, we come in here, we get a point spread function beforehand. She was actually a young woman, a -250. Okay, comes in. So this is all the information I get when I sit down in the exam lane with the patient for the first time. I can sit down here. I get their pre-op refraction, which is key. We'd obviously argue that hyperopes do better than myopes, okay, and low myopes are always the toughest to please. But if I have this information before I sit down, I'm not going to have to backpedal. I get pupil size, so she's obviously got a very large pupil. The Restore implant stops opodizing at 3.6 millimeters, okay, so that's another big issue. Her major complaint was glare at night. She had a PSC cataract. But she also worked night shifts, okay, and wanted to be able to read the computer. So we did a D1 implant. But to take it a step further, I don't like to do high SIL with multifocal IOLs. So she has less than a diopter still. Again, I get this before I even walk in the room. Normal asphericity, so we got, in essence, that's a little higher, 0.267. It's right down here. It's a little higher than where it should be. So 0.267, right smack dab in the middle. I got a pupil size, which you can see on the image, the eye image in the bottom right corner. It's a large pupil. You know, we got to tell her she may notice some glare. And then I get the pupil center. I mean, if she has any degree of angle kappa, you know, you're going to have issues trying to center that lens at the time of surgery. So that's always a very helpful piece of information. All of that's sitting there waiting for me, okay? So the post-operative image, and also the other thing that I like to address is dry eye. And I find that the placido images, the placido illuminations give me an idea if there's any kind of irregularity for a dry eye patient. So I'll know that they have to be started on Restasis or some type of artificial tear. And here's the post-op image. So we've reduced the prescription, we've hit our target, okay? We have a predictable reduction in total ocular spherical aberration, and we're left with exactly what you'd expect. It's almost identical to what you'd expect given a restored D1. It corrects in essence 0.7 to 0.2, or sorry, 0.17 to 0.21, depending on the power of the implant. But that's exactly what I'd expect. So she has some residual positive spherical aberration.
But you didn't use the Technics multifocal because you wanted to keep
No, I didn't do the Technics multifocal because she didn't want glare at night. That's it, yes. That was the issue.
So the spherical ab really didn't come into play in this case.
No, it doesn't. But the bottom line is that, again, I can identify it and simply say, you know, this is what I was doing. No, I don't pick. The idea of picking a premium IOL based on spherical aberration, I think you're missing the boat. Yeah, you're missing the bigger picture. Yeah, but
It only applies to multifocals.
right, well, you know, you could certainly say that if she does have some positive spherical aberration, you know, that there may be some issues. And you're right. Under those circumstances, if her primary issues were, I don't mind glare at night, I want to be able to read, I have this size pupil, you know, that's what we see. You're right. The Technics multifocal would be the expected implant, okay? But her major complaint, you know, and again, even trying to discuss this with PAC was glare, glare, glare at night. And if we knew there was going to be a fair amount of glare afterwards, you know, I'm a fairly conservative surgeon. I don't want to have to then explain myself to her in that regard with regard to the glare. And in large part, the D1 seemed to blend the options as best we could. So that was the decision for this implant. But again, you get that information right off the bat, among other things, when using this instrument. And I think that's really what makes it so unique. I have another office in Virginia, and we don't have this instrument there yet. In large part because we're waiting for the next generation. We were supposed to get that last quarter, but we're running patients just as everybody else is, from, you know, a surface tomographer. We have the orb scan, so we're running them there. We're doing manual pupillometry. You know, I get Ks off of manual Ks and the auto-refraction. I mean, this is all sitting there for you. Not to mention that, you know, there's no real way of applicably getting a wave scan. And you were saying, how do you get your wave scans in the office? How are you getting wavefront information in the office?
Usually before anything's done, you run a wave scan. If it's not available, then I just have to go.
Sure. Which instrument do you use? Oh, you do? Okay. Yeah. So, I mean, it's certainly feasible. And certainly willing to take questions when we're done here. So thank you. Thank you very much.